Assalamu alaikum, everyone. Please settle down. I guess we need to start on time. So we are already, I guess, a couple of minutes late. So, Bismillah ar-Rahman ar-Rahim. My name is Fahad. I'm a surgical oncologist at Shaukat Khanum Hospital, Peshawar. So welcome to this GI session of 22nd Cancer Symposium of Shaukat Khanum Hospital, which is for the first time being held at Peshawar. I welcome you all today. So to start with, I'd like to welcome and ask Professor Zareen to chair this session. He's the professor of surgery at Khyber Teaching Hospital, Peshawar. Kindly put your hands together for Professor Zareen. Thank you. So it's going to be a mix of upper and lower GI today. We have got all the experts, and they are going to talk about different cancer strategies. So the first talk is from Professor Yusuf Iftikhar, who is the professor of surgery at University Hospital of Derby and Burton. I'd like to welcome Professor Iftikhar. Thank you.
Assalamu alaikum. Thank you. Thanks for your invitation. It's a great privilege to be here. This is the first ever interaction with Shaukat Khanum I had. I visited Shaukat Khanum in Lahore previously to see a patient, but not for any academic input. So it's a great privilege. I feel very honored. Who am I? This is it. This slide tells you a little bit about me. I grew up in Karachi, did my medicine from Dow Medical College, then went to UK, and I've done my entire training in UK. This is the hospital where I work now. This is the University Hospital of Derby and Burton. My remit is to talk about esophageal cancer and its surgical approach. Yeah. Esophagus is a very small organ, about 25 centimeter long. That's all. And so much so is talked about it. Chinese, they have got a different problems than compared to any one of us. But you have a big problem in north of this part of the world. And it extends from Afghanistan to Caspian Sea and Turkey. And you have an incidence of nearly 100 plus cases per 100,000 per year. That's the picture where the Caspian Sea area is. We are involved with esophageal cancer in UK. Incidence is very low, really, 20 cases per 100,000 per year. This is a picture of Burgundy, which had the highest incidence in Europe. And it was only because of the excessive use of Calvados, hot red wine and its contents. My interest developed because of my work with this guy. Have I got any control over? Which one is? Chap on the left is standing, Michael Atkinson. All of you who know about esophageal intubation, endoscopic esophageal intubation was actually started by him. Before him, it was all peroperative, transthoracic, Sutar, Mosio-Barbin, and all those tubes were. But Atkinson started putting it endoscopically. And I wrote his first paper on his lifetime work as well. In this picture, there's a very interesting guy. This is Norman Barrett. Norman Barrett was consultant surgeon in London at St. Thomas's. And he wrote something like this, which you already know. And I have put this slide up because I want to correct this forever. He described this as a stomach pulled up. This was the first paper published in BJS in 1951. But it was wrong. This was not the exact Barrett's. Barrett's was actually transformed esophageal mucosa to metaplastic columnar epithelium. And that was corrected by Allison and Johnson, who were working in Leeds at that time. They were good friends with Barrett's, and they named it Barrett's esophagus, but it shouldn't have been Barrett's. And Americans are very particular about it. They actually don't call it Barrett's. They call it CLO. Implication of Barrett's was that the 4% cases presumably developed malignancy. This one is a squamous cell carcinoma, but in Barrett's you get primarily adenocarcinoma. And majority of people with esophageal cancer would present in this stage where they don't really survive. I mentioned the paper which I wrote on Michael's work. This was the paper which was published in the European Journal of Surgical Hepatology and Gastroenterology. That it was their first ever issue. And Majsewicz, who was the editor, who was very good friends with Michael. So Michael sent the paper to him. This was the tube. This is Atkinson tube. This is a post-mortem video picture. And it was because of this problem, the adenocarcinoma in the Barrett's esophagus. You can see the tumor there. And I got involved with surgical part of it because I was trained in Nottingham under a guy called Faiq Salama, who was a surgeon, initially originated from Alexandria. Egyptians are actually brilliant surgeons. They really are. You would have heard the name of Magdi Yaqub, the cardiac surgeon, and he was Egyptian as well. Here you can see one of my trainee, who is now a professor of pancreatic surgery in Queen's Medical Center in Nottingham, Dilip Lobo. Dilip is a brilliant, brilliant surgeon. I put this slide up because all of you know who are involved in esophageal resection, they know all this, but those who are the trainees and who are looking at this picture, most important bit is when you resect the esophageal cancer, you have to move this stomach up into the chest. So you preserve the stomach conduit by preserving this gastroepiploic artery. There's one single vessel which actually maintains the blood supply to the gastric conduit. And you must have that. If you roger that artery, then you lose the gastric conduit completely. You can do resection of all types. This is the total esophagectomy. I've listed the name of the types of surgery which you guys do. Thoracoabdominal, McKeown's 3-stage. McKeown became very famous only because he was one of the principal guy in that time, in that era, where he did his esophagectomy with survival. Post-op deaths are very minimal in his hand. But he only did 163 cases in his lifetime. And all of you who are the esophagectomists, they have done 500 plus cases minimum. This video just talks about hybrid esophagectomy, but I will not show the entire video. You've seen it all already. I'm not here to teach how to resect esophageal cancer. It's only to talk about this is the gastrocolic omentum dissection to preserve the gastroepiploic artery. And why I've put this up? Because the key to success of esophagectomy is preservation of blood supply to the gastric conduit. No matter what method do you use, you can use all sorts of minimal technique and all that, but you have to preserve the blood supply. And it can help if you go back to it again and just show you. Yeah, this is the creation of gastric conduit. This was 1983. 2003, not 1983, 2003. I started doing hybrid esophagectomy, and I used to do laparoscopic resection and laparoscopic creation of conduit. The key to conduit is that you create a tube like esophagus. You don't leave too much of a stomach, and you create a tube, and that goes up. Survival, nice guideline in the early part of the development of the MDT and all that was that 10% mortality from esophageal resection was acceptable. 10% mortality is very high. Most surgeons now have a mortality of 1.5 to 4% maximum. Good units anywhere in the world should actually be able to aspire to have that sort of mortality. Post-operative, perioperative deaths are very minimal. Post-operative deaths, we are talking about 30 days mortality, but now the target has been moved. It's now 90 days mortality. Now, overall 90-day mortality in our unit is 1.5%. In my hand, I'm the principal resectionist in my unit, is 0%. Allah ka karam hai, 2007 till to date, I haven't lost a single patient from esophagectomy within 90 days. And that was the data published in the newspapers in some few years ago. You can see us down there. And it was because of the various development which we had made. In early 2000, harmonica scalpel came in, and this paper was, you see lots of Pakistani lads in there. It was Naseem Wadayach was my registrar, Javed Ahmed was my registrar. He's a consultant in Cleveland, very good upper GI surgeon. He will be here in Peshawar on the 17th to attend your Thoracic Society meeting. Farhan Rashid, you would probably know him because he came to work in Shifa and moved back to UK recently. And these are the guys, and there's another Pakistani down there who was the principal author there. Now, key to surgery and its outcome is that you do early enhanced recovery. And this, I have the permission of putting this video up if it works. It didn't work here. However, this is the day one. And I visited your hospital, Shaukat Khanum Hospital last night, and you guys are doing the same. ERAS protocol. Zubair is your principal resectionist there. And his patient, day 3, I think it was, who I saw, she was lying in bed, very, very well, looked like day 7, day 8 to me. And his patients go home by day 5, I'm told. Our patients go home by day 10, day 11, day 12, is still. Give it to this guy, Don Lowe. Don Lowe works in Seattle as emeritus professor, head of thoracic surgery. He's the one who has started ERAS. He's the one who has started moving patients out of bed day 1. And he is good. His results are very good, and he's a good speaker, and he's a fantastic surgeon as well. Survival from esophageal resection, you can see that T1, T2, T3 have got different outcomes. Long-term survival is still poor. When I started as a young lad, it was 17% 5-year survival. And I'm glad to say that in our unit now it is 37%, and there are other units who are actually even have better outcome. It's going up to within very, very short period of time. In next few years, you will hear that with minimal access and robotic and all that, where the recovery is much better, mortality probably would be, survival would be 50% plus 5-year. If you have got a nodal involvement, the outcome is very poor. So staging is quite important. If you find out early disease, they do very well. And resection in early disease is going down and down as well, because there are other modalities coming in for resection, excision, and endoscopic resection, and all that is very good. Having said that, if you have got esophageal cancer, you are just like this parachuter. If you look at this slide closely, he's just about to land with all the crocs waiting for him. Finally, I would like to tell you about something which we do. And I was talking to Asim the other day about left thoracotomy esophagectomy. Now, you will all think that I'm talking about thoracoabdominal. No, it is not thoracoabdominal. It is just left thoracotomy, opening the left chest through the bed of 7th or 6th rib. Go inside, dissect the esophagus, open the diaphragm from inside, and then work on the stomach from short gastric downwards. The first evolution of thoracic surgery was actually a long time ago. The esophageal resection, 1913, and that was by Torek. This was the resection where he had actually produced a tear in the left bronchus, and he had to take the tumor off the aortic arch, and this was the patient. What he had done is that he had actually put a tube from the cervical esophagus to the stomach, and patient used to feed himself every time if he needed to feed, he'll put it through this tube. And this guy survived 17 years. That's very lucky. Long survivals are, and this was day 12 post-op photograph. Now, the technique was developed by Sweet. So hence it is named as Sweet esophagectomy. Here it says left thoracotomy and phrenotomy only. Phrenotomy because you open the diaphragm. Now, opening the diaphragm, you have to be very precise. You have to identify the phrenic nerve, which is coming down and getting attached to the diaphragm. So you cut it radially. Don't cut through the crus and preserve the diaphragmatic hiatus and all that. I actually do take hiatus with the tumor. I take cuff of diaphragm with the tumor to provide wider resection. The difference between Ivor-Lewis and left thoracotomy is several. One of them is time. We take 2.5 hours in total surgical time to resect the esophagus completely. Anesthetic time, an hour or 2 or 3. Sometimes the anesthetic time is longer than the surgical time. But those are the data which are available. The weakening of the diaphragm doesn't really occur. If you are particular about preserving the phrenic nerve and this supply, then the diaphragm works very, very well. The aim of this particular audit, which I'm going to show you 3 slides and then finish, was to look at the outcome. That if you're doing something on a regular basis, which other people don't do, very, very few people actually regularly use this approach in UK. In China, they do still. And they have done a lot of trial to look at the Ivor-Lewis and the sweet esophagectomy and its outcome. This was our own data. We looked at cases between 2012 and 2021, its surgical outcome and all that stuff. And this was it. This was we had 69 cases. No. See, the median age was 69 in sweet and 67 in the ILO group. Predominantly men. Women do very well with esophageal cancer. I won't dwell on that subject, but I've done a lot of work on my receptor work and all that and published it as well. Somehow, the ratio between men and women is 7:1. This is nature for you. Now, look at the physiological reserve of these patients. If you are operating on people who have good Charlson score, they do better than the ones who have got poor. Pre-treatment, where were the tumors? Primarily, lower third were the ones in the sweet esophagectomy group. We did Ivor-Lewis esophagectomy as well because the 3 other surgeons who worked with me in the unit, they didn't do the left thoracotomy. They were not comfortable with it. These were the clinical stages in those 2 groups. Complications were similar as well. We do get complications, but they don't think that 30-40% complications include all leaks and all that. Very little leak. Radiological leak predominantly up to 4% and about 1% clinical leak. That's what we get. And I wouldn't dwell on that either because there's a whole lecture on how to deal with the leaks and all that. 30-day mortality in the left thoracotomy was 0%. In Ivor-Lewis was 1%. 90-day was 1 and 8. So they do better. They do better. Chyle leak is less as well. Gastric emptying is an issue with thoracotomy, esophagectomy. Ivor-Lewis or McEwan's or whichever method you use, or minimal invasive or robotics, the pyloric function, we don't do pyloroplasty. Never ever will do pyloroplasty, not have done in last 25 years. And I think majority units who are progressing, they don't do that either. If there is a problem with emptying of the gastric conduit, we just gastroscope and stretch the pylorus with a balloon. And that seemed to work very, very well. This is the slide for the resection. R1 resection is still there. Now, why the R1 resection? When Phil Kirk described the extent of the tumor has to be within 1 millimeter of the specimen, that was for colorectal. For esophageal, there isn't enough tissue around. So you are actually resecting different organ than the colon. but it's still we look at 1 millimeter, and so the R0 and R1 resection is defined by how close it is to the external margin. This was the video of the left thoracotomy esophagectomy. I won't discuss that either. Length of stay, I've already told you, is less than Ivor Lewis, but it still is about 10 to 12 days median stay in hospital. 1 year survival, there you are. 2 year survival, 3 year survival, there you are. 5 year survival is actually better than what we used to have. It's about 37%. And would like to conclude this talk by saying that suite esophagectomy is an approach, even in the modern era, where you've got loads of lower esophageal cancer, CVIT type 1, type 2, type 3. This is a very, very good approach because you just need to go into the left chest and everything is done through there. Operative time, if you are a good surgeon, which I believe that majority slides which I see in your groups of resection which you guys do, you are technically actually very gifted surgeon. I don't see that kind of surgeon abroad, not in that sort of number as you have here in Pakistan. Yeah. So you should be able to deliver this very easily. Do believe that suite esophagectomy is the thing here, even in the modern era. It's a procedure which serves very, very well. And having a reduced hospital stay and post-operative time may be more favorable in more frail patients with distal and junctional esophageal tumor. When I say frail patient and older elderly, we operate on patients who are 80 plus. 80-year-old is not a barrier for us. Age group आपने देखा 69 was the median age. 69-year-old यहाँ पे आप बोलेंगे ये तो बूढ़ा हो गया. Don't do that. Age is no barrier. Physiological age is the most important thing. If there is a 70-year-old, if he is fit and if he's got a problem, help him. Thank you. Thanks for listening.
Thank you, Professor Iftikhar, for giving us a lovely insight into the esophageal resection. Thank you so much. So taking it forward, we'll take the question answers at the end of the session. So next is Professor Asif Chaudhry, who is consultant robotic surgeon at Royal Marsden Hospital, England. And he's going to talk about current and future directions in digital robotic surgery.
So, hello and good afternoon and assalamu alaikum. My name is Asif Chaudhry. I'm going to speak about the current and future directions in esophageal and cancer surgery, following on from Professor Iftikhar Yusuf's talk. My focus is really going to be much more on convergent technology and the future of digital robotic surgery that I think is going to impact not only on esophageal cancer surgery, but surgery across all tumor types. And it gives me great pleasure to be at a symposium organized by Shaukat Khanum today. My first interaction with Shaukat Khanum was actually 25 years ago when I just qualified and I did an attachment at Shaukat Khanum in Lahore for about 4 months with Professor Amir Ali Sayed and Asim Yusuf and others at that time, and Mansoor Javed, who became a very close friend of mine as well at the time. So I've been at the Royal Marsden for around a decade or so, about 12 years actually when I first started there. The Royal Marsden is the oldest cancer center in the world, and together with the Institute of Cancer Research is the largest comprehensive cancer institute in Europe, and we treat around 50,000 cancer patients a year. And we're constantly striving to expand and innovate and to see how we can push the boundaries forward, not only in terms of drug development and drug treatments, but also in surgery as well. So as Professor Iftikhar mentioned, although the esophagus is a short organ, it's only 25 centimeters, it's at a very sort of crucial part of the body, running through the mediastinum, through the neck, the mediastinum, and then into the abdomen as well, intimately associated with the core structures of the body. And in any esophageal resection, whatever the approach you take, the key is the radical template of tissue that you take to ensure that you're not only taking the tumor, but the surrounding tissue that potentially bears positive lymph nodes, that could often be sort of present as sort of skip nodes in various positions throughout the mediastinum, but also the circumferential margin around the tumor itself. And so in doing that, the key is creating a plane that runs along the pericardium, goes to the base of the pleura, taking the mesoesophagus fully with both layers of the fascia that surround the mesoesophagus and the blood vessels that come directly from the aorta at that point, taking the subcarinal lymph nodes, going on the surface of the right and the left main bronchus, and down to the trachea. And if you are going to do a 3-stage, you continue with the protection and the preservation of the recurrent laryngeal nerves on the right and the left, in addition to an abdominal lymphadenectomy too. So, we can carry out open procedures, hybrid procedures. So I typically carry out laparoscopic abdominal procedures and then open chest as well. But these are long-established, safe operations that are oncologically safe as well, but nevertheless mutilating by definition, cutting through muscle, cutting through rib. And there are times in which it's important to carry out procedures as an open operation for tumor considerations or individual patient considerations. And this is an example of a left thoracoabdominal esophagectomy approach. Nothing's changing on this. So they've not been advancing. Sorry, I had assumed that everything was moving on there at the same time. You can't put it on this. Advanced income. Right, so there are times in which a left thoracoabdominal approach is appropriate, particularly where tumors are encroaching on the crural structures, or if there's a need to make decision-making with regard to how much of the stomach can be preserved, or to switch over to an extended total gastrectomy and distal esophagectomy with the jejunum being taken up. And sometimes it's better to do that through an open approach with good haptic feedback. Or alternatively, I see tumors like this, massive GIST tumors of the chest, and in this particular case, you can see that the tumor was pushing down on the liver, compressing the pericardium, shifting the heart to the left, and encroaching on the esophagus throughout, and also very close to the IVC. So an operation like that has to be done open, and as long as you can get to the right planes, keep the pseudocapsule intact of a tumor like that, you can achieve great results, and this patient survived and she did very well. However, we are in a technologically progressive era, and robotics has been around for a long time now. And it's only in the sort of, third or the fourth generation of robots that really, things have moved into the upper GI sphere, properly. And you'll all be familiar, or some of you might not be familiar with the Da Vinci Xi robot, which works on the basis of a slave and master association between a console that gives you a three-dimensional view, so looking down at it in the corner of the room, or even that could be in another room, teleconnected, with four arms, almost like sort of old car manufacturing arms, with small instruments that are mechanized at the tips, long instruments in terms of the actual shaft, but very small at the tips. And those arms go into the patient, and within the patient, because of the position of wristed instruments, the manner in which one's able to manipulate the tissue as compared to classic thoracoscopic or laparoscopic surgery is considerably better and easier. And here I'm just starting off showing you my sort of thoracic approach to a robotic esophagectomy. And typically I would start at the inferior pulmonary ligament, separating that away using the hook, and trying to create a plane from there going down to the surface of the pericardium, which you can see just underneath there. And that anteriorly, that's an entirely avascular plane that can be extended over the surface of the inferior pulmonary vein on the right side and over to the left. Now, this is double the normal speed. And the key thing is that when you carry this sort of procedure out, you have to moderate the exact point at which you're applying energy, because it has to be in sequence with the beating of the heart or transmitted impulses within the aorta as well. And it's not difficult to actually sort of burn into the pericardium or burn into the aorta, but that's something that intuitively the robot helps you to moderate. And the robot, with the settings as well, gets rid of normal tremor, and there's a real benefit in the mediastinum, much more so, I think, than compared to the abdomen. So typically for a robotic esophagectomy, I actually carry out my laparoscopic phase, the abdominal phase laparoscopically, but in the chest I prefer to use a robot. And here I'm extending, and I'm continuing with my mobilization at the base of the lung, getting close to the base of the right main bronchus and the membranous areas there. And I often sort of zip around between different areas, free everything up progressively, and then get to the point at which I'm taking the esophagus out. So here I'm taking the esophagus and then developing the plane on the other side of that. And I'll get down to the position of the right main bronchus nodes and the subcarinal dissection. And a lot of this, surprisingly, can be achieved simply with the hook, without the need for any sort of advanced energy devices. Even though I love the harmonic scalpel and I use that extensively in the abdomen, what I found is that if you are in the correct plane in the chest, you can carry out a very precise dissection on the surface of the aorta. And there aren't that many branches that you come across. There are only really three principal branches, and then networks that run between them. So this is an old video from about 5 years ago that I took. Now I tend to use the fourth arm of the robot to actually drag the esophagus across, and I take both layers of the mesoesophagus, and I take the thoracic duct separately, consistently, with a clean dissection on the aorta. This patient actually had a BMI of 30, so I didn't want to show you a very straightforward, simple one with no fat in it. It's all achievable, however you do it. Once I've carried out my dissection completely, I make a tube out of the esophagus. I circumcise it effectively to make sure that the mucosa is proud. And I'm going to go through this further. Then I deliver the conduit. And then I do an end-to-side robot sutured anastomosis using a fill block suture, which is a barbed suture like V-lock, but it's softer. And I've been using that consistently since 2016, when I carried out the first robotic esophagectomy in the UK. At that time, at a point at which there were only a few centers in Europe overall, and I was initially trained by someone called Richard van Hilgersberg, who's a pioneer of robotic esophageal cancer surgery in Utrecht. So what you'll see is that the use of wristed instruments and 540 degrees of motion at the wrist with these devices, very, very easy to suture in a minimally invasive fashion, and you get a very clean anastomosis. And I did have some leaks within my first 20 or so cases, But in terms of the learning curve with this, in the past, people used to talk about 100 cases, but with progressive improvements in the nature of robots that are coming through, it's becoming better and better. So now people talk about less than 20. If you are an already established open surgeon or minimally invasive surgeon. So, I'm just going to zoom past all of this. I don't want to dwell on that too much, but you get the idea in terms of the actual approach. So the Da Vinci Xi also gives you an option of using Firefly, which is fluorescence guidance. And, this could be used using indocyanine green for passive use, just showing perfusion of tissue in the esophagus and the conduit. So here I'm just sort of showing you that, but I'm going to talk a bit more about that later. Okay, so this was the very first robotic esophagectomy patient who had his operation in 2016 at the Marsden. That was the same patient 4 weeks later. And I think the key benefits that we've seen in terms of our data, not really in just the length of stay. Length of stay is it's a surrogate marker for how well things have gone. But the key is how well are people getting back into the activities of daily life at 3 and 6 months? How much of a more long-lasting impact is there on them? So just as they're getting over the end of their perioperative chemotherapy, and that's really where the benefit is. So when you don't have post-thoracotomy syndrome, things get better in terms of your movement, your nutrition, your physiological state, and that's the improvement. And this is the same patient 5 years later. And there was a document, it came on TV and ITV, and he's very happy and he's cured. Okay, so things are bleak in general for esophageal cancer. 2/3 of patients present with metastatic disease, 1/3 don't. Of those, half of patients can get long-term survival, and we are seeing that progressively with different approaches. This is just a very quick view of where I put the ports. So these patients tend to be in a left lateral semi-prone position with a trapezius type association with the ports coming in from the side of the patient, with me sitting at the end. I had the pleasure of taking Prince William, Prince of Wales, through one of these operations. I know Shaukat Khanum had a very close relationship with his mother, with Princess Diana. And since we carried out that first esophagectomy, I helped to form a new international society called the International Upper GI Robotic Association, together with 3 colleagues, Richard van Hilgersberg, Peter Grimmager from Mainz, and Philip Chu in Hong Kong. And since then, that's expanded massively with membership from around the world, from the United States, North and South America, Japan, Korea, throughout Europe. And the number of centers is progressively increasing. And this is important, not because I helped to set something up, but it's important because part and parcel of this, and the only way of actually becoming a member of this association is to demonstrate that you've done a minimum of 50 cases for which you're able to submit your data as part of an international registry that we then look at. And that helps us to look at learning curves and to help to set some sort of international standards that people can buy into. And what we are seeing is that with this sort of approach with proctorship, mentorship, and assisting each other, it's much easier to actually establish new programs in new institutions and new countries where nobody's actually doing it, and to try to maintain some form of consistency. And we have a number of publications that I'm not going to go through the data through specifically, but I can point you to that if anyone's interested later. So none of this surgery happens in isolation. So because these are difficult cancers, and our aim is to not only try to cure these people, but to give them the best possible outcomes, both in terms of longevity and function. At the Marsden, my colleague Bill Allen, and together with David Cunningham, back in 2006, set up the MAGIC trial, which was the first perioperative study looking at perioperative chemotherapy with surgery, that demonstrated very clearly that there was a 13% benefit in 5-year overall survival between surgery or perioperative chemotherapy. That's old data now. That's been superseded by the FLOT4 trial with Salahuddin Al-Batran in Frankfurt, Nordwest. And there's a further improvement in survival up to that sort of 40 to 50% with the particular cases who met the inclusion criteria of that study. And now we're moving into the era of immunotherapy, IO. So I initiated the first trial for perioperative immunotherapy. In checkpoint inhibitors, the problem with esophageal cancer is that its tumor mutational burden is relatively low. So you don't get a massive, response as you do with melanomas and renal cancers. There's a difference. So we postulated that perhaps in combination with chemotherapy, you could increase immunogenicity and maybe there'd be a benefit at that point. And when we set this trial up, no one quite knew how patients would behave, whether they would just crash before, big thoracic surgery with pneumonitis, but it was safe. So, that sort of trial is over. The final results aren't back yet, but we do have some of the translational data coming through now. And part of that was looking at circulating tumor DNA. And what we found in that is that using the Natera, 95% of the patients who went into the trial had positive circulating tumor DNA at the outset. 25% still had circulating tumor DNA positivity after they'd received 4 cycles of FLOT with avelumab. And of those patients, a number no longer had circulating tumor DNA immediately after surgery. All of those were node negative, incidentally. But then any patients who then subsequently continued to have circulating tumor DNA positivity after 4 cycles post-operatively, if it was still positive at that point, none of them were cleared using that chemoimmunotherapy approach, and all of these people progressed. So, which clearly is suggestive that alternative post-operative adjuvant approaches need to be figured out, and rationalizing approaches to new trials for that is now of need. So, what's the future? So, I said that I was going to talk about convergent technologies. I'm not sure how much time I've got actually, but when we think about who we are as surgeons, I was quite moved by this old sort of series of paintings by Dame Barbara Hepworth from the 1940s, who came in to watch people operating. And what you see is this very intimate interplay between eyes and hands and minds and collective approaches, okay, and our limbs. And really, digital surgery and the future of surgery is all about mechanization and automation and optimization of all of those faculties. Okay, so when we look at eyes, optics, camera displays, layering of different lights and different smart information is augmentation of that. Hands, arms, tools, sensors, mechatronics, mechanized smart instruments, the sort of robots I've already shown you. With a brain, artificial intelligence, and layering or connectivity, it's all part of what we might see in the future. Now, you might have heard the term digital surgery bandied around. So, this is really a combination between data analysis and applications that then emerge from that, not only in the setting of preoperative planning, but intraoperative information and simulation, and also assisting each other, and also looking through auditing our own repositories of videos from operations that we've carried out. But not in a static way, but also including analytics that can then be fed back to surgeons. But where are we at now? So, sure, we all know about intuitive Da Vinci machines. There is a plethora of new robots coming into the market now, but most of the robots that we're seeing actually work on the basis of old technology. So the standard sort of robotic arms have existed in car manufacturing since the 1980s. There's nothing particularly new about that. Things are getting slightly better. So, for instance, I would say that the new Kawasaki Medicoroid, Hinotori Medicoroid robot is particularly nice in terms of the arms. XI is well established. There are sort of single port approaches that are being used. Visually, all of these companies are still using standard either TFT monitors with stereoscopic glasses that one has to wear, or immersive consoles, but nevertheless, relatively old technology. And I don't think we can look at this in isolation. So we have a sort of medical offering that we focus on, but we're in a world that's increasingly an extended reality world, with a transition between virtual reality, mixed reality, and augmented reality. So if you haven't come across the terminology, or the definitions for that, in augmented reality, there's the idea is that you have a static digital set of information that you can't necessarily interact with, but is present around you. In virtual reality, the idea is that you immerse yourself in a completely artificial domain, such as the metaverse. Mixed reality is something in between the two. And visually, much more is out there and much more is coming. Okay, so there is autostereoscopy, volumetric display, holographic display that has been used in other industries for some time and has continued to develop and is coming into the medical world now. So companies like Techna with a real view holoscope, have created this sort of holographic image of the heart that can be used for interventional cardiology, that projects in a way that you don't really have to kind of cover your eyes up, but you can actually have an image and a three-dimensional sort of image that you can then use to assist with what you're actually working on with the individual patient. EchoPixel creates holographic standards, CT and MRI scans that you can actually manipulate and look at in much more detail rather than static screens. And, this is at a time that companies like Apple are producing the Vision Pro, creating augmented reality, not sort of VR systems where we can look at imagery around us that we can actually engage with no analog interface. And this is going to come into our space. So rather than having these sort of hard robots, we will have better visuals sort of coming through in the future. It's just a matter of time. But then the question that arises is, what do we actually want to see? Okay, we can see our tumors and the lumps, and we know our standardized templates of what we want to remove. We know statistically where is good to remove things, where is not so good to which is the old way in which we've been thinking about things. There's been some gimmickry over the last sort of decade or so using HoloLens and other things where you can project preoperative images into real-time spaces while you're operating, but it doesn't really necessarily change much of what we're looking at. What we need is things that are easily wearable. Okay, so perhaps the future might include this sort of thing, contact lenses that project things, and these already exist. This sort of thing started in 2017. Samsung have been involved with it. There are already 220 patents with contact lenses that you can have smart quantum dot pixels and projections of imagery that can be merged from either preoperative imaging or other sort of smart information in relation to the physiology of the patient. And this sort of thing is likely to come in the future. There are challenges in terms of bandwidth, in terms of how you have connectivity with them, and also how rich the environment can be. But all of that's going to be dealt with, I think, gradually. Artificial intelligence is an area of massive development at the moment. Everyone's talking about generative AI, but also visual AI and semantic visual AI analysis, looking at driverless cars, for instance, smart ways of assisting in transport. But in surgery, for instance, the approach of trying to get a detailed machine understanding of what the operative field shows. This has also been developed over some time. Fundamentally, it's based on data acquisition, pre-processing, processing, and post-processing, where you train AI systems to initially demarcate the edges or the boundaries of what can be seen, and then create sort of predictive models that can be assessed versus the original sort of training model. And this sort of thing, has been used in animals. It's been used ex vivo and in animals. And this is, this slide basically shows the STAR system that was published in 2016-17 by Shardeman from Johns Hopkins. And this was an automated system that took near-infrared markers placed on 2 loops of bowel with an auto-suturing device that this machine learning model basically devised a plan for where the auto-suture device would place the sutures to create an anastomosis. And what they found is that actually the sort of mechanized AI system was better than in terms of how good the anastomosis came together as compared to the surgeons who were operating at the same time. Okay, and this is all going to get better and better. We've been so I have a startup that's been working on multi-layered convolutional neural networks for delineating the boundaries and borders with thoracic operative fields to try to create a tool that assists surgeons as they're operating to tell them what different structures might be in an automated way. So is that the esophagus? Is that the aorta? Is that the bronchus? Or is that just fat? Is it something else? But the future, and this shows you an example of how well the AI system actually predicted things. I'm going to go through two things very, very quickly, okay? So in terms of AI, endoluminal systems to predict the nature of polyps already exist, okay, based on white light techniques. Fluorescence-guided surgery is moving very rapidly from passive to tumor-directed antibody-affibody approaches, and we've been working on photoimmunotherapy approaches with that as well at the Marsden to give us tumor-directed imagery that can help us delineate where the tumor is within a field. And I think the way forward in the future will also include AI techniques converging together with digital pathology, confocal laser microscopy, optical coherence tomography, possibly mass spec approaches as well. And together with a massive advancement in soft robotics that mimic far more sort of organic, real world sort of approaches that are not based on rigid devices with very large forces involved. So as my time is up, I'm going to leave this and happy to discuss any of this with any of you in the future. Thank you very much.
The next talk will be by Dr. Shiraz Marker, Associate Professor of Surgery at John Radcliffe Hospital, Oxford, UK. And this will be a virtual talk about gastric cancer, latest advances in management.
Hello, can you hear me? Hello, hi. I hope you can hear me.
Yes, we can hear you.
Perfect, thank you. So first of all, thank you very much for the opportunity and the privilege to talk to you today. It's hard to follow Asif, actually. I know, and that's a really, really stellar talk from Asif. So it's very interesting to hear some of the advances going up the Marsden. So as you said, just as a brief introduction, my name is Shiraz Marker. I'm Associate Professor of Upper GI Surgery in Oxford and Academic Director of our Surgical Trials Unit here. My background is I am Sri Lankan Muslim, Assalamu alaikum salam. So I'm just going to really try to talk to you about some of the latest advances really around gastric cancer. And these are really just my thoughts. It's a very broad topic. So hopefully I'll cover most of what we want to hear. So bear with me 1 second. I'm just going to play the slides now. Yeah. And then I'll play now. So that should work. Firstly, I'd really like to thank the organising committee for the opportunity and the privilege to talk today. My name is Shiraz Marker. I'm Associate Professor.
So we cannot hear you, Shiraz. Can you just...
Yeah,
now
surgical management that are rapidly advancing.
So again, we cannot, there's some problem with the voice, I guess.
Okay. Hold on. I think it'll come in a second, I think. Hold on 1 second.
Mm-hmm.
So traditionally, oligometastatic disease has been quite boring, as you can see by the picture with my children falling asleep. But I really hope that I hope to get across that it's a really exciting area for research. It's probably going to be something which is going to directly impact most of our treatment pathways in the next 5 to 10 years. So this is the trial called the AAO-FLOT3 trial. It was essentially a non-randomized cohort study. But what was fascinating about this trial was that they were able to identify a limited number of patients, around 60 patients, who had what was deemed to be limited metastatic disease, of whom a portion went on to have surgery. And that portion who went on to have surgical intervention, there was a dramatic improvement in survival. So this provided a rationale or a thought process around, can we treat oligometastatic disease or limited metastatic disease in gastric cancer with an aggressive approach? In the UK, I published this paper a few years ago now, but this is our data looking at resection of hepatic metastasis in patients with gastric cancer. And what we showed is that if you present with a hepatic metastasis to a limited degree and a gastric cancer, and you go on to have surgical intervention of both the primary cancer and the hepatic metastasis, your overall survival is dramatically improved. Now, I appreciate this is extremely biased data, but it's important to provide a rationale and test our traditional hypothesis or our traditional treatment approaches, which have been largely speaking palliative chemotherapy in this kind of cohort. And this is being tested in the future in more detail with a Renaissance trial, which is just, I think, about to complete recruitment or just completed recruitment, which is essentially testing the ability of detection of oligometastatic disease and aggressive treatment with surgery, along with FLOP-based chemotherapy versus just standard systemic therapy. And we'll have a primary endpoint of overall survival. So I think this is a really interesting trial and potentially something which will really influence our practice moving forward. So that's really providing the rationale for why we need to detect oligometastatic disease. But the question is how do we define it? So I'm very grateful to some of these slides from Professor Van Hilgersberger, who's my mentor in robotic surgery. But he designed the OMEC study, and this was really an important international study to try to create a uniform definition of oligometastatic disease, and also to establish recommendations around treatment strategies for oligometastatic disease. This piece of work is a huge piece of work, but it's broadly speaking designed into 5 main areas, of which the first sort of 3 are now completed. These are the key stakeholder groups which took part in the work, which, as you can see, is very large in nature and covers the panacea of specialties working in gastric cancer. First of all, they started off with a meta-analysis, and what they showed from this meta-analysis was that treatment of any oligometastatic disease with local and systemic therapy led to a prognostic survival benefit of 25 versus 11 months. This was most marked in treatment of a liver oligometastatic disease with an improvement in survival of 24 to 8 months. And in meta-analysis, again, aggressive treatment of oligometastatic disease was associated with a much improved overall survival, with a hazard ratio of 0.39 for liver metastasis. And I think this is really important in providing a rationale for why we're doing the work around oligometastatic disease. So following this, they went on to do a Delphi process, which was really trying to look at how we should define oligometastatic disease and could we provide really any kind of treatment recommendations around it. So they gained consensus, and this is a really key slide. They gained consensus in defining oligometastatic disease in gastric cancer as one organ with less than 3 metastases, or 3 metastases or less, I should say, or one extra-regional lymph node station. They also gained specific definitions around organs, and that was around liver metastasis, such as bilobar liver metastasis allowed 2 or more, and unilobular liver metastasis around 3 or more Mets. Lung metastasis had to be unilateral, and up to 3 metastases allowed. Adrenal metastasis had to be unilateral, and brain and soft tissue metastasis had to be 1 metastasis present to be defined as oligometastatic. And importantly, the consensus in terms of how you should assess after systemic therapy for oligometastatic disease was that there was no progression in the number of metastases. So they didn't have to have a regression. There was just the absence of progression. And what they gained in terms of treatment recommendations was they gained a consensus around systemic therapy, followed by restaging for localized treatment for synchronous oligometastatic disease and metachronous oligometastatic disease, except disease-free survival of more than 2 years. They gained consensus on the minimum duration of systemic therapy had to be at least 3 months, and there was fair agreement on the type of systemic therapy after local treatment for oligometastatic disease, which was believed to be adjuvant immunotherapy. And I think this is really, really important when we start to think about future avenues for research. And I know there are obviously ongoing trials which will look at this
in more detail of the kind of panacea of treatment of systemic chemotherapy, followed by localized treatment, followed by adjuvant immunotherapy or adjuvant chemotherapy. So that's really what I have to say around oligometastatic disease. Now, when we start to think about minimally invasive surgery, obviously as surgeons, this is the cool area, and this is my kids being very cool. And this is something we're all interested in. What is the minimally invasive approach for gastric cancer, and how does it sit? And I often think we talk about trials. Trials are, by definition, the gold standard. And I hope to challenge some part of our beliefs really around this. So first of all, when we talk about external validity in a randomized controlled trial, it's the perfect picture, for example, like this. You go to a photography, you take great pictures of your kids, and they look like angels in that. But this is probably more of the reality. They're a bit more, not perfect in many ways, but probably more characterful and more representative of truly what you see when you go from practicing your technique in a tightly controlled randomized controlled trial to real life clinical practice. And we have to evolve to improve that transition. An example of this is the TIME trial, which was a randomized controlled trial of minimally invasive versus open esophagectomy. It showed a massive reduction in pulmonary complications, published in the Lancet within Holland, but it was a limited number of centers that took part, around 6 in total and 4 from the Netherlands. When we looked at this trial in terms of national practice in the Netherlands, what we showed was that after the trial, there was an increase in pulmonary complications seen in a minimally invasive group. So that trial actually has absolutely no external validity. So the trial was very tightly controlled, the technique within the trial, but when it was performed nationally, they were unable to replicate the results of the trial. In actual fact, they had adverse outcomes associated with the technique. Now, when we look at laparoscopic gastrectomy, the Logica trial was published in JCO from Holland. Recently, this shows laparoscopic versus open gastrectomy. It was powered to length of hospital stay, but it showed no benefit to laparoscopic gastrectomy in terms of length of hospital stay, complications, or oncological outcomes. However, what I was really interested in is what happened before, during, and after that trial. So I asked them for their Dutch national audit data, and what was fascinating to me was that if you look at the solid black line, there's a massive increase in the rate of laparoscopic gastrectomy in Holland after the trial and during the trial. And if you look at the solid blue line, what you see is that there's a real reduction in major complications, or complications, I should say, in total, after the trial. So perhaps what could be argued is that every trial has a timeline. And this trial was perhaps conducted a little bit early, but what it did lead to is it led to the safe dissemination of laparoscopic gastrectomy within Holland, which is really, really important when you start to think about future trials. And this really illustrates this a bit more, which is that if you look at the outcomes for the patients comparing laparoscopic and open before the trial, they're all kind of sitting in the middle or maybe in favor a little bit of open. When you look at it after the trial, 30-day in hospital mortality, overall complications, severe complications, cardiac complications, and length of hospital stay are all improved in favor of the laparoscopic gastrectomy group, which really implies that in actual fact, if you're able to tightly control the quality of surgery within your trial, and then you're able to disseminate that across your board or across your country, you're able to provide a vehicle for safely disseminating a complex surgical technique. And then it comes down to how do we really measure surgical quality? So what I advocate for is I'm a very visual person, and I think it's really important to measure surgical quality through interrupted photos or through video-based analysis. And the reason why I say that is because if you look at the quality of these pictures, the quality of the dissection and the lymph node harvest, how do you capture that meaningfully in data? Typically, we look at lymph node harvest, but that's really dependent upon the pathologist in many ways, and it's not really representative of what happens. And furthermore, if you collect the video, what you're able to do is you're able to annotate every step of the operation into a series of tasks and subtasks. And from that, you're able to look at the errors. And then if you collect the outcomes of the patients, you're able to correlate that with the outcome, and you look at consequential and inconsequential errors, which is a technique called OCRA. So I work in an area really looking at surgical quality within randomized controlled trials. And this is 3 phases to this. One is standardizing the technique so that everyone knows what operation they should be performing. The second is credentialing surgical experience, where we typically would ask for surgeons to submit videos to take part in a trial. And then we score those videos, and if they're of sufficient standard, they enter the trial. And the third is monitoring performance during the trial in real time, so that you provide regular feedback to surgeons as they are undergoing the trial. So I'll give you an example of this. So this is robotic assisted gastrectomy, which this is me performing a couple of procedures working with Peter Grimminger, one of my closest friends in surgery. And the potential advantages of the robot are really around better visualization, also improved ergonomics and more precise tissue dissection. And I think what's important is to be honest about what we're looking at with robotic surgery. This is a paper a few years ago from the European Association of Endoscopic Surgery. But what it showed was alarming to me, is it showed that a large number of surgeons, around 57% of surgeons, are taking prescription medication for long-term pain relief associated with performing open or laparoscopic surgery. And that number is obviously dramatically reduced with robotic surgery. So we've designed a study called Organ, which we hope to gain funding for within the UK, looking at open or laparoscopic versus robotic gastrectomy for adenocarcinoma. What I hope to do is challenge this. At the moment, around 17% of gastrectomies in the UK are performed minimally invasively. This is despite us having a remarkably low 30-day mortality and 90-day mortality, and also relatively good outcomes in terms of oncological outcomes. And our overall survival from gastrectomy is reasonable. So what I want to do is test whether or not we can use a trial to safely disseminate robotic gastrectomy across the UK. So we designed a stepwise cluster design, which will allow centres to transition from performing open or laparoscopic gastrectomy to performing robotic gastrectomy within the trial. And at the end of the trial, what you'll have is you'll have all centres performing robotic gastrectomy. So you start off essentially with your centres performing open surgery. Then they submit, once they're randomized, their centres randomized to the robotic arm, they submit 2 videos. If there's sufficient standard, they go, then they're allowed to enter into the robotic arm, and then they perform the robotic gastrectomy for the foreseeable time of the trial. But what it means is that every surgeon in your trial has gone through a surgical quality assurance program. And at the end of your trial, you'll have 20 centers and all of their surgeons performing this technique to a very high standard. So it means that your trial is a safe way of disseminating robotic assisted gastrectomy across your country. And this is really what we powered to. We powered to a textbook outcome and health-related quality of life and surgical ergonomics. But this is why I think surgical quality assurance is so important to safely improve the dissemination of robotic-assisted surgery. And I think this is both not just niche within the UK, but niche internationally. And so important, because you can train surgeons, you can pair them with a robotic mentor, you can credential them before they enter the trial, as we talked about. You can standardize the technique through creating standardized video-based analysis tools. And you can monitor performance and provide regular feedback. And the final thing I really wanted to talk about was surveillance. So what really comes after the trial? After the surgery, sorry, I should say. And I hope to make you as excited about surveillance as my son is about the snow. So I'm very fortunate to be the chief investigator for the Sarong trial. This is a trial of surveillance after resection of esophageal and gastric cancer. This is my study team within Oxford, and we've received funding from the NIHR to undertake this trial. And what we aim to do is we aim to test whether or not intensive surveillance after completing curative treatment improves survival and long-term health-related quality of life in patients with esophageal and gastric cancer. So we're randomizing patients and looking at whether or not intensive follow-up improves 3-year overall survival through the detection of oligometastatic disease and aggressive treatment of that, and therefore can improve long-term health-related quality of life. Patients will be randomized after surgery to either having 6 monthly CTs for the first 3 years and an endoscopy at 12 months, or standard clinical follow-up with symptoms triggering their investigations. And I think this is a really good trial because it includes 952 patients across the UK, 476 in each group. And what I think is really important is to evolve as an academic. So what's obviously very hot at the moment is circulating tumor DNA. Within this trial, we'll conduct a biomarker study led by my colleague Richard Owen in the picture, which will collect ctDNA at the same time as the patient has the CT scan in the intensive surveillance group. So we'll look at whether or not ctDNA is able to accurately predict a recurrence or potentially identify patients at risk of recurrence down the line. So what's exciting in many ways about this trial is that we have the UK arm of the trial running, funded by the NIHR HTA, and we'll recruit 952 patients. We have a parallel trial running internationally, which I gained funding for in Scandinavia, and Jesse Elliott's leading from Dublin, along with centres from Germany, France, and Italy, which will recruit, again, 952 patients. And what it will allow us to do is two things. One is it will allow us to examine the external validity of the results of the UK trial within a contemporary cohort in Europe. And also we'll be able to put the data together from over 1,800 patients to a single study and a meta-analysis at the end to really identify which patients actually maximally benefit from aggressive surveillance. I'm also very grateful to funding, but also the name of the trial. My heritage is Sri Lankan, as many as you know. And this is a picture of my son wearing his first ever sarong. So in conclusion, what I think is an exciting time for the management of gastric cancer. I think we're going to move towards aggressive treatment of oligometastatic disease. I think robotics is here to stay, and it's definitely the future of this profession. I think surveillance is going to become absolutely crucial to drive that detection of oligometastatic disease to then go on and treat it. And I think, as I said, the future is very bright in gastric cancer. So I'd really like to thank you for your time. And I'm sorry I can't be with you today, but I'm very happy to take any questions by email or anyone to reach out. So thank you again for the time, and I'm sorry I can't be there.
Thank you so much, Shiraz, for a lovely presentation. So next, moving forwards to the lower GI section, I'd like to invite Professor Pervez, who is Professor Robotic Colorectal Surgery and Director of Robotics, European Academy of Robotics. Professor Amjad will be telling us about watch and wait and the paradigm shift in it. Thank you.
Thank you.
And they show us. Thank you very much, and thank you once again for the very kind invitation. मेरा इंटरेस्ट है कोलोरेक्टल सर्जरी में और मेरा इंटरेस्ट है टीचिंग ट्रेनिंग में और मिनिमल इन्वेसिव सर्जरी में. I'm going to talk about something which is not very favorite for surgeons, but I'll talk to you about organ preservation and just give you an idea. And I like to sort of put across one simple message that if you've given chemoradiation for whatever local indications from the local MDTR and the patient have got a complete clinical response, we all have a duty to discuss perhaps organ preservation. Not everybody needs surgery. So this is a single take-home message from my talk. For the last few years, I'm spending my time between this place. This is Himpalimo Foundation in Lisbon, and in Doha as well, which is Hamad Medical Corporation. I spent 2 weeks at both places teaching people laparoscopy and robotic surgery. But the real message is this: things come in fashion. Now, laparoscopy a couple of decades ago was fashion, and if I don't do laparoscopy, I'm not sexy enough colorectal surgeon. Now, robotics have changing the goalpost. So everybody has suddenly become laparoscopic and robotic colorectal surgeon. You know, certainly the new visiting card have been sort of started with this. The rationale is this: MIS surgery for people who look after people with cancer is a mere tool. It's not the religion. Religion for surgeons is anatomy. Learn anatomy. This is one such picture. I have a privilege of going around the world and teaching people, and this is one such picture sent to me that this is the first laparoscopic abdominoperineal excision done in our district hospital, and you should be proud of this. And they wanted my comment on this. And I said, okay, well, if most of you would look around it and say, perhaps the stoma is a bit lateral, but the rest of the holes look okay. So I said to them, please send me the picture of the specimen if you want a really good, honest feedback. And most of you would agree that this is slightly suboptimal. This is not the specimen if I had a rectal cancer I wanted. I didn't want those little scars. This is bad surgical oncology. And the rationale behind this is we got to produce specimen after specimen, whether we do it open, laparoscopic, robotic, or automation, or AI. This wins the day in the end. Biology wins in the end. So if you're trying to learn something and you're fascinated with laparoscopy and robotic, you got to remember biology wins in the end, and the anatomy is a key to that. So this is one message, and I can perhaps finish my talk here. I don't need 15 minutes to teach them anything else. Learn this, please. So what is a complete clinical response? Why we are looking to save organ? And who are the ideal candidates that we should be considering for watch and wait policy? And when they do regrow, when cancer goes away, you say you don't need an abdominoperineal excision, we'll put you under intensive follow-up and surveillance. And when the cancer comes back, are we harming these patients by putting them into this program? Because maybe now the cancer has progressed, the surgery is technically more difficult. And this is what I'm going to share with you very quickly. Idea is not new, started with anal cancer. Norman Negru did 3 cases. If you look at the original paper in 1970s, he put 3 cases where he gave chemoradiation to anal cancer, and he came back and the cancer had gone. He actually was going on holiday. That's why he couldn't do an abdominal perineal excision for the first patient. So he came back from his holiday, realized there is no cancer to do. So he did the other 2 patients the same way. And that was, this whole philosophy is based on 3 cases. Angelita Habergama is from Brazil. She postulated the same thing for low rectal cancer. And now this is where the paradigm is moving. And these are really what I call the 3 things that you need to know. You need a finger examination or a bioprobe, which automatically tells you that the cancer have to be within the reach of the finger. So these are the ideal candidates to be put through this program. You're going to have an MRI scan, and you're going to have an endoscopy or the pictures of endoscopy. So this is what the 3 tools are needed to come to this. Why is that? TME, although have reduced the local recurrence from 30 to 40% to single figures in most centers, but still it is a debilitating operation. This is Dutch trial data. More rectal cancer are seen in old and frail people. If you look at this, the older you are, or the older they were in the trial, the higher the mortality was, because there are comorbidity associated with this. So although TME is ideal, but there was a problem with this. And although both radiation oncology has improved, this is SBRT, where very focal radiation is given only to the tumor target, and surgery has improved with laparoscopy and robotic surgery becoming a precision tool. It is still a toxic mix when you operate on people with very low anastomosis, because it has functional implication. This is one such data from Heidelberg. Have a look at this. Fecal incontinence, urinary incontinence, male sexual dysfunction. As the tumor goes lower and lower, the proportion of patients suffering with these morbidities goes higher and higher. So although you have a better local control, you have bad functional outcome. Similar thing through the Danish study showing similar figures that this is a morbid operation. This is the original paper which she selected, less than 7 centimeters from the anal verge, from T2 to T4 disease, and she showed that perhaps these patients do not need operation. Time is a key. What would predict? Historically speaking, we surgeons were operating 6 weeks after chemoradiation. Chemoradiation, 6-week wait, straight to surgery. We have realized that radiation works longer with timeline, and now 12 weeks is seen as a gold standard, and longer you wait, higher the chances are that you would have a PCR in your study. And this is the myth. If I don't do it at 6 weeks, it would become technically difficult operation, and I have higher complication rate. This is Memorial Sloan Kettering data, 6 weeks versus 12 weeks, operative, post-operative mortality complication, exactly the same. And this is, again, a similar sort of thing, 7 weeks versus 11. This is a Greco trial. The French group did this trial, and they said that if you wait after 8 weeks, you have higher complication rate. That's what started it. This is a couple of years ago. If you look at it, morbidity is 49%, but most of their complications were medical complications rather than surgical complications. This is our own data from International Watch and Wait database based around in Lisbon. 22% of these patients, when they're put in the program, would have regrowth. So started with first patient a few years ago. She basically decided herself that no, there is no tumor on endoscopy, no tumor on MR, and I couldn't feel anything. She says, why we have to operate? Why can't we just wait and see if it comes back? And we put her in the program, and now we are sort of part of this group as well who contribute data to this. The longer we wait, the better it is. We know about this. Which are the ideal candidates? So ideal candidates are people who are facing a permanent stoma. If the tumor is low, involving the sphincter complex, and the decision up front is perhaps an abdominal perineal excision, they would be the candidate. People with very low rectal cancer would have a functionally threatened, because they would have a low anterior section syndrome when you do a low joint. So they are the effective patients that you should be thinking about this. How do you assess? You could see this starts with first endoscopy, post-treatment endoscopy. There is hardly anything. And then you're going to put them in surveillance and keep doing the picture. It's a pictorial story that you have to look at, because the pictures would change before you could feel anything different, both on MR and on this. So let's talk about the last half of my talk. Are we harming our patient if we defer operation? And by that, I mean, would they have local regrowth? This is a new word. They don't call local recurrence. They say local regrowth because it's come within the lumen. Or would they have distant metastases while they are waiting for the surveillance to happen? So this is the data from R3 Center. I started in Portsmouth and Poole a few years back now, 14, 15 years ago. And then I moved to Lisbon. So this is a 3-center data where we look at people who are operated after. This is 470 rectal cancer, 124 had preoperative chemoradiotherapy rate. We give very selective chemoradiation. This is a point to emphasize. You know, people, we do not give radiation based on the height of the tumor or end disease. If the margins are either threatened or involved, or if they have EMBI, they get neoadjuvant therapy. Otherwise, they will go straight for surgery. So we look at the cohort who went straight for surgery after treatment, or people who waited more than 12 weeks. This is an outcome data. You could see that all the numbers were very, very similar. Right. So what happened when they regrow? You know, is it a worse thing when they do develop a regrowth? This is a paper actually written by one of the guys who worked here in Peshawar. He's our fellow. He was our fellow in Lisbon at that time. He looked at our data. Irfan, I don't know whether we sat here or not. We looked at people who would end up having an operation following the regrowth in our group. So these are the indication for chemoradiation. Total number of cases, 124. 46 had incomplete response. They went straight for surgery. Complete clinical response, 78 patients in the surveillance program, 23 regrew. So these are the 23 that we operated on. As you could see, people who had deferred operation were facing mostly abdominoperineal because the tumor was very low. And you can also see time from surgery, 6 weeks who went straight for surgery, and median of 16 weeks after, watch and wait program where they end up having an operation. No increased morbidity was seen in our hands. Same planned operation that the patient originally had planned for. No oncological difference in our data when you compared those people who regrew, operated, and versus people who had upfront surgery. So we concluded that people with initial complete clinical response and local regrowth can be safely managed by deferring the operations. You could wait safely very easily within the program. And delayed minimally invasive surgery appeared to have no negative impact, both on clinical outcome as well as oncological outcome. People talk about surgery in general. I talk about anatomy. This is one such tool, and this is a very non-sexy part of the rectal cancer surgical operation. This is mobilizing left colon medial to lateral from one place to another. All this tool is doing is traction, countertraction, and separating embryology, an envelope of embryology that can be easily separated between the two things. If you could operate in these oncological plane or anatomical plane, the likelihood, I can't change biology. None of the surgeons could change biology of the cancers. The likelihood is that they are likely to have less morbidity. And this is the only thing which is in the control of a surgeon. This is one such patient, regrowth patient, obese guy, BMI 40 something, on warfarin, regrew after about a year. This is anterior dissection under the seminal vesicle done with a robot because this is what is in fashion these days. And we do most of our rectal cancer surgery using the robotic tools now. And I want to this is mainly for the interest of the surgeon. This is a technically difficult operation, dividing Denneuvillier's fascia just at the level where you are. And then once you've divided the fascia, because behind those are the little pulsating vessels where there is neurovascular bundle running, where I could cut the nerves and they would have impotence problems, so to speak. Now you've divided the fascia. And the key really is that now the robotic tool would stay parallel to the specimen. Look, it is running parallel to the specimen. The straight stick of laparoscopy come perpendicular. We could do laparoscopic work. I'm not saying you can't do it. It's technically more challenging. It allows you to get to a very awkward angles, very difficult places to get to. You could see this is the last inococcygeus ligament being released posteriorly. This is the start of the TME dissection. You can look up, you can separate embryology from other. Just to give you an idea, this wins in the end, nothing else. So what are the protocols for following these patients up? Have a look at this, how intensive the follow-up is. every 4 months, they would have CEA, digital rectal examination, endoscopic assessment done by the surgeons, 4 MRI and 2 CT scans. That's the resource you need if you want to put these patients into the program. And that is a difficulty in a country like Pakistan, or for that matter, most other countries, middle to low income countries, to have those resources be pulled along. And people would slip through the net and they would have a problem. But if you're looking to set it up, this is the logarithm to look at it. So, in conclusion, Mr. Chairman, ladies and gentlemen, I hope I stuck to the time. I apologize if I overrun it. Organ preservation is high priority for some selected patients, and we've spoken about those patients. It needs resources. It needs centralization of the data, centralization of the service, and it is, a control environment, as I said, and more people are producing data to show this. I'm very grateful for the organizing committee to still inviting me after so many years, and I hope I had something to show and to at least teach one bit to the audience. Thank you very much for listening to me.
The next presentation will be again a virtual presentation, virtual talk by, it's a physical presentation by Professor Dr. Jameel Ahmed, who is a consultant robotic and colorectal surgeon at University Hospital, Nottingham, UK. And the topic of discussion would be when things go wrong in MIS.
Thank you very much. First of all, I'm not professor, hopefully sometime. Thank you very much for invite. It is a completely different topic. You had a very thorough and scientific presentation just before me. And my topic is the people sitting 3 rows behind. And it is very much related to their daily life and their practical aspect while they go back to their work and training. My name is Jameel Ahmed. I am colorectal surgeon. I am lead for robotic services in my hospital. I'm also a college tutor and honorary lecturer in Leicester University. So let's talk about how things can go wrong. I have nothing to disclose except some slides which I have borrowed from my fellow and some videos from Professor Amjad Parvez. When we are doing a laparoscopy, or perhaps any approach, there is always a risk. And when you talk to your patient, and it's an important aspect which you talk to your patient that there is some risk of injury to the bowel, surrounding structure, your ureter, or any organs such as spleen or pancreas. And that's a very important aspect to know in the surgery, whatever you do. And we are specifically going to talk about laparoscopic approach and their consequences or something wrong when during the laparoscopy surgery. Let's start with the very basic and first step. When we put the ports, I'm sure you all are very well know that there's a safe way of doing it. But there is always a small risk of injuring any structure. I'm sure all of us know that there are some incidents in our lives when you've seen a port gone into SMV. I was a part. I have seen a port gone into the aorta, and I have seen a port gone into the liver. When the patient had a big vesceromegaly, liver was the first thing to come under the umbilical port. So we know there's a closed technique, there's an open techniques, and these are the things which is important to understand that putting a port is an important skill. And when you are learning laparoscopy surgery, obviously it's important to make sure that whatever technique you use, open or closed, you know what you're doing. This was one of the closed technique. Now coming to one of the injuries let's talk about ureteric injury. So it's important to know your correct field, and you know what is the actually spleen look like, and what is the pattern. If anything goes wrong in the pattern, likelihood that you are going to injure something. And if you lose your pattern and recognition of pattern, that's where the problem is. This is another video where you can see that the assistant very nicely picked up the ureter and given to the surgeon, and surgeon is going to divide it very nicely as well. And you can see the pattern is completely different. You generally, if the laparoscopic experienced surgeon will not see this pattern, will not see this big vessel. And this means that if you are in the wrong place and the wrong pattern in front of you, you are going to do something wrong. For a trainee point of view, where you should be careful about ureter is there are some area when you need to be aware of when the ureter is going to come very close to your dissection area, and where you need to be aware of that, and you need to be vigilant and make sure that you see it. So there can be injuries, can be proximal, mid ureter, or distal uretaric injuries, depending upon which part of ball is you're removing, or where the section you are doing, either in the pelvis or in the colon. And the evasive technique, obviously, a lot of people would like to repair themselves, but in UK, our practice is that if we have done something in other area, like the ureter, we ask our colleagues to come and help out. How to prevent it? Obviously, anatomy, as Professor Amjad was talking about, anatomy is the key. If you are in the right anatomy, you know your anatomy, less likely you are going to cause any damage. But it's not only just anatomy. You need to know about the patterns and about the steps of your operation. Is uretaric stent is going to make it safe? No, there is not enough evidence that putting a stent will prevent the injury. And obviously, laparoscopy has a higher risk of getting uretaric injury, and the stent will not prevent that. This is one of the meta-analysis which has shown that actually putting a stent will not make any major difference. However, it might give you a bit of human factor in yourself that, okay, I am putting the ureter, I am putting a stent in this patient because this is a difficult stuck divertical disease. And that human factor will actually give you a conscious feedback that you have to be careful about that section. But obviously, if you are generally, if you're going to put a stent, that might not make any major difference. People have put those ureters stent which are highlight, have a light in it, and also use ICG to improve. Yes, if these are very fashionable to do it, but main thing is that direct inspection of the ureter is the most sensitive method to assess and prevent the injuries. Let's talk about the bladder. This is one of the patients who had sigmoid colon stuck to the bladder, and probably this is, I would not say injury, probably it was known that bladder is going to come off, and if that happens, you just put some stitches and repair it. Then splenic injuries are more common in laparoscopic surgery as compared to the open, and if you have those, you have to be very careful when you are going to mobilize the splenic flexure. It's generally avulsion injuries and or tear in the splenic capsule. Just to show how it looked like, obviously you can see the bleeding coming from this hilum area, and if you pack it, hopefully it will help to contain the bleeding. Obviously, there are a number of other aspects such as electrocautery, hemostatic agents, and using advanced methods such as meshes and stuff, and at the end, if it doesn't work, splenectomy is the main way to get out of this. But you need to know what are the possible options you have and what will work. It's not everything will be applicable to all patients. When we talk about the splenic pancreatic injury, they are less incident, but be aware of that, and especially when the patients are when you're doing a lateral mobilization and splenic flexion mobilization, where in the lateral side, putting the patient in the lateral side. With some center in UK they do it, and there's a chance that you go behind and cause injury to the splenic tail. Diaphragmatic injury can happen. What happens? Hopefully you will see it, and if that you can just need to repair it by reducing the pressure and put a suture in it, and make sure that patient is not in a respiratory distress, and if needed, put a chest tube in order to ensure that patient recovers well. Small bowel injury is another common injury, and especially when you are doing overstretch. As you see, the overstretching has caused some tear over there, and which needs looking at later on and putting a stitch on it. Bleeding from various aspects, which I will show. Well, one of the aspects is when your retraction is too much while you are doing an operation. Your assistant pulling it back, and that's where the bleeding coming from the mesentery mesocolon. So obviously these are the areas which you need to be careful about, and this part of the bowel is going to come out, so it's easy to just put a hammerlock to stop it, dry it, and then carry on with your operation. This is another video. So as I think Prof was trying to show in his video, if you are not respecting the tissue and not going into your right plane, bleeding will happen. And if in this, when you are operating in a blind way, you don't know what vessel is behind there, then likelihood that bleeding will happen. So it's important to know what is your plan and what is behind the structure before you starting dissection and dividing it. This is another. I think hammerlock has come off, and this is where you have to pack it, go back, and then visit and see if the bleeding has stopped. It is a resected part of the bowel, and then it is because it's the back bleeding, it stopped itself. What about the bleeding from the pelvis, presacral bleeding? It's important to know the presacral vessels, and when they bleed, it's very, very difficult. And so if it bleeds, it's a very stressful day in the theater. So be aware of that. And I'm sure this anatomy and these aspects, most of you know. Yes, robot also can cause the trouble. It's not the tool who makes everything. So fancy tool can also cause the problem. Here you go. So this is another bleeding from the presacral vessel. So it's important that you see, you anticipate this where the vessel is. Try not to go that area, and obviously if bleeding happens, need to take appropriate measures. And as here the bleeding was, he just gone into and just stopped it by holding the bleeder. This is another video which shows that when you have a bad view, if you can't see, you cannot operate. Very simple principle. If you think that you can't see, but you know the possible plane is there, you are just taking a big risk. And if you are taking that risk, then probably consequences would be like this. So you have done one mistake, and now you're going to do second mistake, which is going to use monopolar in order to stop that bleeding. You are ignoring that bleeding. The bleeding won't stop until unless you talk to that. And now he just realized, and then it goes from bad to worse. So this is another example. Again, bad visual. No, you cannot see. If you cannot see, you again, the chance of making a risky step and doing a bleeding, making it bleed and getting it worse is there. So in pelvis, it's important that it's not just about bleeding. You need to be aware of the only venous bleeding. There is arterial bleeding and obviously injury to the nerve plexus. What are the other risk factors? There are some factors which are related directly to the surgeon, which is skills, which is approach, and obviously there are other factors which are related to the patients. These are tumor factors, and patients, if patient had a preoperative radiation, previous surgeries, or the location of tumor itself. If it is a distal tumor, is a pelvic male pelvis, narrow area, then the chance of having error is much higher in that area. And sometimes it's difficult to, due to this difficult anatomy, it's difficult to get a good control on the area of bleeding, and it's important that you go back to the basics. Pressure, calm down yourself, get your team ready, get the anesthetist on the board, and then approach. So there are a few steps which you need to be aware of, especially in the pelvic bleeding. Do not use monopolar. Try to, if you know the bleeder, you can see it. Do not use blindly, and if you have to use it, use bipolar. And then in advance, you can use the fragment wedging technique. And then if you are going to use diathermy, probably spray would be better. There are some other techniques to tamponade it, and you need to know as a trainee that what is the available tools you have in your theater. Do you have a surgery cells? You have a surgery floor? Or what are those tools? It's important to be aware of those. If you don't know about those hemostatics, you will not be able to ask, you will not be able to have them, and obviously it will help to control the situation. People use this pin. Now, I have probably, I've never seen it in my life, but they think that if you apply it, it improves the bleeding controls. But if just need to be aware of that, this is the one which you never seen it, you asked for, and you're going to use it first time. So best of luck, because you never used it before. So try not to go to that situation. Bailout. I think this is very important to know your limitations. Okay, the bleeding is going to continue. I am not going to stop. Okay, let's rethink it. And here comes again human factor, and I'm very into those things. Sometimes you suck into the situation and you go from bad to worse to absolutely disaster. So you need to stop where I have to stop here, where I need to call for the help. It doesn't matter if you are very senior, you can call another colleague who can come with a fresh eye. He can look and he can help out you, or at least you make a decision which is a bad decision, but you got another guy with you who's a part of the bad decision, and then you are in a situation you can talk about that. Two of us being there, and generally getting other help will help you to control the situation. Close the abdomen and pack it, close it, come back next day, and this is an option. It has been done. People doing it, and people will do it in the future. So this is not something which never happened. It happened, and it will happen. So there is no alternative of having good exposure. There is no shortcuts. Good laparoscopy skills are key, and know your skills is important. Knowledge of anatomy is important. You must know your tools and their limitation. Every tool has a limitation. Robots has limitation, and you also need to know your own limitation. I'm going to quickly show these very informative laparoscopic videos, which Professor Parvez gave me last night. So this is here. There is no view. The bowel is just keep coming, but he ignores it. He just, he can see a little bit of window, and it gives a lot of traction. And obviously what will happen, everybody can predict that will happen, and this happens. So it was predictable for any skillful laparoscopic surgeon what's going to happen here. And now he's going to put a clip there to solve the situation. But now what happened, his focus is there, but his anatomy was here. He needed to go here. This is the right hemicolectomy proposed. Another tool is used in a wrong way. You never use a hard tool between the two vessels. Here we go. And obviously the vessel behind start bleeding. And now he end up, as he had a bit of a vessel behind, so he was able to solve the situation. This is other example. When you are operating very close to the colon, just look at it. This is not the anatomy, not the view, not the plane you are generally look at. So obviously bleeding was a likelihood because you are in the wrong plane to start with, and because you packed it and you gone another place, you thought that it's going to improve. Obviously you are dividing a bowel, the omentum on a place where you can't see. That bleeder has come back to you. Look at it. So so that monster did not go away. So it come back, and now you have no choice but to clip on the marginal. And that is going to have a consequences on your anastomosis. That is going to have a consequences on your length, and also consequences on your outcome. Technical failure. So it is very well known, and most of people say that if there is a vessel, you name it, you clip it. And this is what I've been told for last 10-15 years. And here this is ileocolic vessels being just divided with the harmonic, and obviously it slipped, and there was a lot of tension in the tissue, and bleeding was predictable. So most of the time when you look back, when there is disaster happens, if you deviate from the basic principles, when you ignore the anatomy, when you ignore the layers, you don't ignore the patterns, then disaster can happen. Some of the disasters are not in your control. For example, in this, the echelon gun just broke. It is just a technical failure, but luckily it was second fire, so just taken out, and we put a new one. Small bowel injuries are not uncommon, but it's the problem here is that sometimes you just can't recognize them, and they go unrecognized. The next day patient comes with a lot of problem and a peritonitis, and you see there was a small bowel injury. Another, again, a major deviation from the principles. You are taking a big bites, and you have taken the right ureter in your hand. So this is another important aspect. So this is the patient who had a marginal been taken away, and you hope that it will work, but it won't. yeah, sometimes it's good to be lucky, but it's unfortunately not all the time works. So this is the black part of the bowel now. So what to do? Obviously, you have to come up here, and you don't know how you're going to get your transverse colon down. Too much pushing from the CDH29 when the stump is very stuck and very stiff, you can make a hole. Now, these guys were very clever. They used that hole in their favor, improvised it, and got the hole. Got the. There you go. So this is the other way of doing it, but they managed to make join together. So this is it's gone back to the original. Okay, next. So in conclusion, I think it's important to know the critical anatomy and typical point of injury, and be aware of that, and try to tell yourself. I always ask my fellow, do you think we should go there? I know the answer, but it's important to verbalize it, and it helps. It helps, and a lot of time they give me a very good advice. Don't do that. And presacral bleeding is a disaster. You can go into the big mess, but you need to be you need to know about that and need to be able to prevent it. And the best way to not to get into the trouble. Apply pressure if it happens, pack it, and resuscitate. You should know the adjunct to control the bleeding, and you need to be able to stabilize the patient. Main thing is that control on yourself. Don't panic. You are the pilot of the ship. If you panic, your assistant, your theater staff, your anesthetist, and everybody, it's going to be a small problem will become a bigger problem. Once if you have control on yourself, you are calm, you are collected, you are going to talk clearly to your assistant, to your nurse, and to your anesthetist. And that is the key. It does not matter how big problem is. Anybody can run into the problem. It's important how you manage the problem, how you talk to the people and come out of that. Thank you very much.
The next talk is about advancements and insight in laparoscopic colorectal cancer surgery, navigating the path to minimally invasive excellence. And it will be delivered by Dr. Muhammad Fahad Shah, who is a consultant oncological surgeon, Shaukat Khanum Hospital, Peshawar.
Assalamu alaikum, everyone. I guess you are already bored, and not bored though. We have already overrun a little bit, but I'd like to go through my presentation as quickly as possible, just like an F-16, I believe. Yeah. So let's start. So today I'll be going to talk about insights in minimally invasive colorectal surgery, and talk about a little bit of our own data. So I have no disclosures. There has been innovation, has already been there. We started from fiber optics, then pouch surgery, then lap colectomies, then robotics, which is the new thing. And I don't know where the world will be going. It's AI, as Professor Chaudhary mentioned that, quite in detail. So when laparoscopy came first, so open surgery was already there, and it was well established, quite a lot of evidence with that. It was cheap, but when the people were talking about, it's laparoscopy is a new technique, long learning curve, so they were not accepting it as much as they should have in the beginning, so they needed some evidence. So first lap colectomy was performed in the early 90s. Then some people from the Cleveland Clinic, they did a few randomized controlled trial. They did show some marginal benefits in laparoscopy. Then Barcelona trial, they did a few cases, which again showed that it was some kind of comparable to the open surgery. Then classic, a randomized controlled trial, it was done. They showed some benefits in the colon cancer, but not much in the rectum, as there was a 34% conversion and a higher CRM positivity rate. Then again, color, it was a randomized controlled trial for T3 N1, N2 rectal cancers. They did randomized control trial between open and laparoscopic surgery. In that, the conversion rate had come down to 17% with some of the CRM positivity in both these groups. Then came the Korean, which was a landmark trial, and it showed good results. The conversion rate was less, and the CRM positivity rate was only 2.9%. So the only reason for that the surgeons became more and more experienced with what they were doing, and they were quite confident with that. So by that time, laparoscopy had already been established. So now the world is moving and everybody is talking about, robotics. Everybody knows, this is the new thing in the market, robotics. So we know it gives us good magnification. There is, endo resting and enhanced ergonomics and everything, but still it needed some evidence. So again, the same talk about, and this time it was between laparoscopy and robotics. And who will win? Time is telling us. So the evidence, still there. In colorectal cancer, it has shown minimal advantage, especially in rectal cancer in the urogenital. They have got better nerve sorry, excuse me. So better nerve preservation and urogenital functions in rectal cancer surgery. So now this is the future, I believe. The robot will be telling us what to do. I guess there's no sound. So the robot will be telling us what to do and what not to do, I believe, yeah? So talking about Shaukat Khanum. So Shaukat Khanum, it started in 1990, started with open surgery, then moved to laparoscopy, minimally invasive surgery, and then started surgical oncology fellowship. It was 2012 that the fellowship started, and it was approved by CPSP in about 2017. And till now, there have been around 50 fellows that has graduated through this program. And I've been lucky that I was one of those fellows. So now did some training abroad as well, came back and started a department along with my colleagues in 2021. So we'll be talking about data from our own center in Peshawar SKM about the colorectal cases that we did. So far, in this short period of time, we have performed 313 major elective colorectal cancers. Out of them, there were 2 were converted, and one was because of the bleeding from the splenic flexure that Dr. Jamil showed us very nicely. So the only message from here is, you need to know when to convert. The ego shouldn't come in between, that I'm going to proceed with the laparoscopy. So, patient comes first. So we do get more of younger patients. So usually they are much fitter. So ASA2, few of them were, 3 and 4. So we have performed so far about 118 cases in colon and 195 rectal cancer cases. Most of them in colon were right-sided, and in rectum, they were mid to low rectal cancers. Clinically, as you know, that there's been no screening program in Pakistan. So we usually get T3 and above tumors, no early tumors that we get. Procedure-wise, in colon, we have done, most of them were right colectomies. We have preserved quite a few of the sphincters as well. And abdominoperineal resection, about half of them. We had R1 resections in about 3.3% of our cases. Length of stay varied from 6, mean was 6. We had a fair share of complications as well. So anastomotic leaks at 2.3%, but internationally it is about acceptable is about 8%. We had few readmissions, mortality, and few morbidities as well. This is the thing that I wanted to show you, that we had leaks as well, and how to manage this is important. So clinically stable patient having a leak, day 5, having few comorbidities, did a CT scan on her because of the lower abdominal pain. which showed some air leak around the anastomotic site, which is not always a nice. Did a sigmoidoscopy, which showed that there's a hole, small hole, 2 to 3 centimeters. Did a sigmoidoscopy on her, which confirmed that there's a hole. And then we treated with endosponge. So we were able to, save the sphincter in that patient. And after 6 weeks, the picture on the left is after 6 weeks, and then that it is completely healed. The anastomosis, we reversed her as well. So this is our paper, we published it in Lahore. It showed our own experience from open to lap. Initially, we had, started with lap, then we did open, and then we did lap. The data was collected about right hemicolectomies, and as and when we gained more experience in a lab, so we were doing more and more difficult cases with those, and our results got better with that. So we had a good experience with laparoscopy now. So the disease-free and the overall survival was much better. Nothing is possible without a good team. To be honest, I had a lovely team working with me at Shaukat Khanum, especially my colleagues Zubair and Irfan Square, both of them. And at the end, these three, they really played a major role in what I am today. Thank you, Dr. Amir, Dr. Shahid, and Prof. It has always been, it was nice, and it's still nice working with you. Thank you for your time, and I guess I haven't taken much of your time. Thank you. Thank you. So I guess being the moderator, we'll move to the question answer session. So Professor Zareen, I'll ask the speakers if they can please come and join Professor Zareen if there is any questions or anything. Please, would that be on? So, do you want to ask a few questions? You can have a seat, Prof. So any questions from the audience? Yeah, I know you all are bored with yep.
If the decision is easier if the tumor is within the reach of which I call a digital MRI. I think I'm a bit skeptical if I can't feel it, if it is above the reach of my finger. What are in your centers? What criteria? Because do you rely on the endoscopies and MRIs only, or to what will be?
Yeah, okay, I'll use the same. It's okay, doesn't matter. So I think if you look at it, the ideal patients are the one that you could feel and touch. So within 7 centimeters, most people have got about 7 centimeters. Some surgeons have got longer finger maybe, but if you could feel it, then it is perhaps safe to put them in a surveillance program. And if you remember, anything which is beyond the tip of your finger is potentially a sphincter preservation operation. So you could save their sphincter. They're not facing a permanent stoma. Other important thing to remember is the stenosis. Sometimes when even they are within your reach and after treatment, there is a narrowing of the tumor response. They are very difficult to assess endoscopically or with finger. So if people develop a significant stenosis, we usually advise them that it's better not to watch and wait, because they are the potential risk of tumor coming back and you are getting delayed to pick this up. So stenosis and anything that is beyond your reach are not a good candidate to put into the watch and wait program.
Fahd, my question is to Dr. Fahd. You talked about leak from after anterior section, right? Do you have any experience of putting stents in?
Sorry, putting stents?
Stents for leaks.
So the leaks that happened, they were usually we performed an ultra low kind of an anterior section. So there was no space for putting a stent in, and it was within the reach of the finger. So at that you cannot put a stent because of the sphincter and everything, and it was quite easily reachable. So we had, and it was contained, the collection. So I had to put an endosponge in it. So one question to Prof. So we usually get patients with new adjuvant. chemoradiation with CRM positivity. After once they have the new adjuvant is finished, the CRM is still positive, so what to do in that circumstance? Do we need to go for operation, or do we need to give them some further treatment? I don't know. What's your...
Now, there is a lot of talk about TNT, or total neoadjuvant therapy. What they're trying to do is to move the goalpost for chemotherapy from adjuvant setting to give everything up front, called consolidation chemo or whatever you want to call it. But that would not change the margin. A positive CRM need an extended resection, full stop. There is no other way around it. So more chemotherapy, more radiation is not going to change anything. And perhaps those particular subgroup of patients, small number of patients, who would need radical dissection, extended dissection. They're at a high risk of urogenital functional or dysfunctional problem, pelvic bleeding, and so forth. So these are generally tougher patients. We don't send them back for more chemo because that's not going to change anything. That's a local problem. Chemo is for systemic control. I have a comment and a question to Professor Iftikhar, if I may. You showed 35% CRM positivity rate with esophagus, I just want to know, because CRM for rectal cancer, for guys like us, we are condemned to 30% local failure rate if I get R1. What is the experience in esophageal surgery? Perhaps a question for both of you to say that what implication it actually has to your patients.
First of all, as I mentioned in my talk, that R1, I believe, is very different in esophageal cancer than colorectal cancer. Because of the behavior of these patients, they actually behave much, much better in terms of a long-term outcome. If you have had a good response to neoadjuvant treatment, FLOT especially has made a lot of difference. I will divulge slightly from your question. I was talking to yourself, right, earlier on. The key to treatment of esophageal cancer is actually immunotherapy, chemotherapy, and those advancements which has made the difference. Surgical techniques haven't really improved things so much. It is the new adjuvant treatment and the immunotherapy which has improved the outcome. And I think that's the way things are going in esophageal work. And R has to change. 1 millimeter margin has to change. Field work has to go, and somebody else has to come and define esophageal cancer resection differently. Maybe Nick West, yes.
I think
Shiraz wants to say something.
Say something. Go ahead.
Yeah, Shiraz, go ahead.
Yeah, I mean, to be honest, I actually have to disagree with you politely, I'm afraid. I really believe our goal as surgeons is to remove the cancer in its entirety. So I really believe in the value of a circumferential R0. And I believe that patients with an R1 do recur locoregionally. So you have to know, and the parallel is very clear in my mind to rectal cancer. So I agree with Professor Parvez in many ways, which is I think you have to, if the margin is threatened in those patients, I would give them chemoradiotherapy with the goal of stimulating a local regional response to achieve a circumferential R0. If the margin isn't threatened, then their pattern of recurrence is most likely to be distant, so they will benefit from neoadjuvant chemotherapy and a radical operation. But for me, the goal is very much to achieve a circumferential R0 with a radical D2 dissection, and I firmly believe in that. And I think as a goal, otherwise, why are we bothering as surgeons? So I really believe that we have to try to treat what we can locally aggressively. I'm be interested to see what Asif says as well.
Yeah, I actually agree with you, Shiraz, but I don't entirely disagree with Professor Sayyid Iftikhar Yusuf either, in the sense that, certainly with FLOT, we know that a complete pathological response can be up to about 20% or so, which does help. And, as biological agents, as immunotherapy improves, perhaps we'll, have more sterilized little scatterings of cells, beyond the principal tumor that might have made things R1 in the past. But I do think that surgical approach, planning appropriately to decide when to operate is very important. And in terms of the template that I mentioned in my talk as well, ensuring that you are following an absolute embryonic sort of template along, taking the whole of the mesoesophagus, taking a wide circumferential margin at the crura, and also tailoring your approach. So, understanding that you can take a right-sided thoracic approach, a left-sided thoracic approach, a minimally invasive or abdominal predominant approach, tailored around the circumferential needs of the specific tumor and the individual patient is vital. So, our aim should always be to get an R-naught resection whenever possible. And, our rates are, not so high. And they vary, at different centers. But, that's it. That's what I would say.
I guess.
Can I just add one more thing? You have mentioned about preservation. In esophageal cancer, we have noted that number of cases who had a positive response to the chemotherapy, neoadjuvant treatment, their resected specimen has not shown any tumor whatsoever. We need to have a marker. We must find out a marker which will identify those individuals who have responded that way so that we don't resect the esophagus. And that is a challenge to all of us, to identify a marker which will tell us that patient has responded positively, complete response, and to neoadjuvant treatment. That's the future.
Maybe if I
So
could just-
Dr. Tariq wants to ask a question.
Assalamu alaikum, everyone. It was a wonderful session. My question is from the colorectal surgeons. So regarding rectal CA, when we offer the patients TNT for CRM positive patients, so when do you, does it affect your surgery if a patient receives radiation in the start of the treatment and then 6 months of chemo, and or if a patient receives radiation in the end of the treatment and then you go on for the surgery 2 months after the radiation? So what as a surgeon is better for you, radiation in the start of the treatment as per Rapido, or some other trial, or radiation at the end of the treatment, chemo radiation at the end of the treatment and followed by surgery and 4 months of chemo in the beginning and then 2 months of radiation? So what as a surgeon would you prefer for us to consider CCRT in the beginning or CCRT in the end, or does it affect your surgery or not?
First, the most important thing that you have to take away from this meeting is that historically, published evidence so far, none of the trial with chemoradiation, particularly radiation, have shown any survival benefit. So you can give me any name, Rapido, OPRA, Progide, Polish studies. You look at them, none of them improve survival. It's the local control you're after. Second important thing is that there is too much fashion of giving chemoradiation. Remember, chemoradiation would never account for bad surgery. It would, if I do the first operation badly, radiation is not going to improve the problem. So the important thing is then to select patients who would benefit from giving chemoradiation. And in our sort of setup, and we have published this in Fortsworth group, over 1,000 rectal cancer, even in the time of open surgery, not necessarily laparoscopy. We did 22% chemoradiation rate, consecutive patient. Because I trained in Basingstoke, I came with that sort of mindset, so to speak. Only indication in our setup historically have been if the CRM is within 2 millimeter or involved, or if there is a T4 tumor. In recent time, EMBI have been added in the last sort of 5-6 years, because that has become a fashion now. And oncologists want to pick those patients plus minus EMBI because they want to give chemo for various reasons. Because Gina Brown showed that EMBI is a surrogate marker of a distant disease, right? So if they have EMBI, if they have CRM positivity or threatened, they will get their treatment, right? We, in our sort of setup, it is not what I prefer. What is really important for patient? If they do not have EMBI and they only have CRM either involved or threatened, they would get a standard chemoradiation and they would come to surgery at 12 weeks. We would assess them. If they haven't got a complete clinical response, they would have a surgery. If they have EMBI, we would give them chemoradiation and they will get all the chemotherapy up front, and we would operate and we would assess them again at 6 months. If they have a complete clinical response, they go into watch and wait. But if they have not got complete clinical response, we'll operate on them. And I thought I had shared with you our data and publication that actually it doesn't make any difference in terms of surgical approach, technical difficulties, and clinical outcome and oncological outcome, even if you operate at 6 weeks, 12 weeks, or at 6 months. The key really is to pick those patients who need this treatment. The knee-jerk response in colorectal cancer in general and around the world effectively is, it is somehow trying to be taken over by the radiation oncologist and medical oncologist, and surgeons are very happy to give it away, because I really do not want to do a big fat guy with a low anterior section, it's better that he disappears. You know, I very happily give this away. This will not change. The key really is you select your patient who would benefit from this. And it is difficult. Difficult operation remain difficult. These two guys have shown you fantastic data from esophagus, and Shiraz is already on the line, and he sort of shared with you their long-term outcome. A difficult operation become less difficult with appropriate training and appropriate tools, but it never become easy. So if I'm looking toward my radiation colleague to make my life easy, it is not going to happen. Biology wins in the end.
Thank you. I think just to add a comment that the practice varies across, and if you look at the UK North, we do the slightly different, Midlands is different, and South is even further. So in the country, within the country, there are quite different approaches. What I'm trying to say. So the as basic thing is the CMR, but some people are more aggressive, some centers are more aggressive, some are less.
Okay, thank you.
So I guess Dr. Shahid wants to ask a question.
My question is to the upper GI surgeons. Wonderful talks from both of you. But lower esophageal tumor adenos, which is, you know, or maybe say type 1 geojunction tumors. What is your approach? Do you treat them with cross, or do you treat them with, I mean, we used to treat them with magic as well, but now it is, you know, different. But in your centers, do you treat them with chemoradiation or just chemotherapy for the type 1 and the lower esophageal adenos?
Right, so our standard approach at the Marsden is perioperative flot, followed by surgery. In selected cases, where we feel that there's a particularly threatened circumferential margin, we do sometimes advocate chemoradiotherapy, surgery, and then nivolumab subsequent to that as well, you know, subject to, you know, how things look. But there's very careful planning around each individual case like that. But the backbone of it tends to be perioperative chemotherapy and surgery. Shiraz, do you want to?
Yeah, we're exactly the same in Oxford. So we very much advocate for perioperative flot from the majority of these types of cancers, unless the margin is circumferentially threatened. I think, you know, in the UK, NICE has obviously licensed nivolumab in the adjuvant setting after chemoradiotherapy, and that's sort of, I would say, probably in very recent months has slightly changed our practice. We've become a bit more comfortable giving chemoradiotherapy in probably more of these kind of threatened margins than we would have done typically. We would have typically just done a much wider resection, but now I think we're being pushed a little bit more to give some chemoradiotherapy up front and then an operation and then adjuvant immuno, probably just because of the NICE licensing. But that will obviously, I think, will change shortly. But yeah, absolutely.
Just to add that, we also have PET CT scans as standard for all patients preoperatively or pre-treatment. And when there's a particular, when there's any issue about the threatened margins, locally advanced cancers, and we want to see the extent of the response, we might then also do a follow-up PET CT scan as well to see if there is any sort of differential reduction in SUV at any point. And that can just help with that sort of careful planning approach. So much as we follow protocols, try to define protocols, we also do go off-piste subject to the individual needs of the individual patient too. And I think that's really important.
Thank you.
Thank you. My name is Habib Khan, clinical oncologist from UK and currently in Canada. So just a quick question about lower GI cancer I wanted to ask. You just mentioned about like threatened margins, long-course chemoradiotherapy and going for surgery. So are you considering TNT approach for most of the high-risk patient at the moment? That's what my understanding was, that we are considering TNT up to a short course chemo and then going on for organ. That's, I presume that's the right thing I'm saying. Okay, that's good. So second thing was about organ preservation, Opera trial. So I know it's more in palliative setting kind of thing. So have you had a chance of looking into that one, and what's your experience, especially in the elderly? And we find that these group very manage well for working with Professor Min and all. He is a harboring of things. So what's your take on that one? Because here we see quite a few advanced cases, locally advanced and elderly with significant comorbidities. So what your take on that one would be in terms of those ones, just for everybody to know? Is just,
I know Professor Sunment have been long advocate of contact radiotherapy, and he's published fantastic outcome data. But the problem is this is not widely available, as it were expertise, or not many centers have adopted that technique. As you know, Rapido initially showed excellent outcome with PCR rate, short course radiation, then give chemotherapy, and then look at the PCR rate after resected specimen, 27%, I think. As you know, there is a follow-up data that has been published now that they have higher local failure rate as well, or regrowth. So now we're moving away from short course. If we give chemoradiation, the standard is long course chemoradiation now, unless the patient is frail, it's done in a palliative setting, then they would have a short course. And they would get all their chemo up front, because the high risk that we identify is EMBI. And that's why they're going to get their consolidation chemo or upfront chemo. If you're talking of palliative setting, it is to do with short course, of course, because A, you are palliating, B, they are symptomatic, C, they are very, very comorbid patients. So, you're not looking at long-term control of the disease or local problem. So short course, particularly with SBRT, which is available in Lisbon, for example, a very focal radiation, very precise radiation with less toxicity. So that's our approach there.
Thank you.
So
Before we finish, I want to thank Shiraz. Shiraz, it's Ifti here from Derby. Yeah, good to be on the same stage as you are, and it's a real honor for me to be with Ajmal and Asim.
So in the end, I'd like to say, give the mic to Professor Zareen to say a few words about this session.
It was an excellent session where speakers, national and international speakers, they share their experiences and their knowledge about treating GI tumors. It was an excellent session in the sense because it was much educating for the people who are budding surgeons and who are young surgeons and trainees also. There was special emphasis on minimal invasive, especially laparoscopic and robotic surgery, and which is the future of treating GI cancers. Hope everybody would have benefit from this. Myself, I've received a lot of knowledge from the speakers. Thank you all for coming to this city and sharing your knowledge and your experience. Thank you all, and hope to see you at some other occasion, inshallah.